One, Dr. Charles Chabert, urologist and director of the Prostate Clinic here on the Gold Coast. The following video is a highlight of contemporary management of BPH, or in essence, how we look after men who've got urinary symptoms related to an enlarged prostate, and this certainly pertains to my practice here on the Gold Coast. So if we start off with the current trade-offs when it comes to the management of BPH. Historically, the paradigm has been that men either had medication in the form of alpha blockade, or alternatively, if their symptoms were too severe or they didn't improve with medical therapy, or if there were complications related to an enlarged prostate, those individuals were then offered a TURP, or a transurethral resection of prostate. Now, the advantage to a TURP is that it does remove a lot of tissue. It is a highly effective way at unobstructing a blocked bladder. The trade-off, however, is that the procedure itself is relatively invasive. It does require up to about three days of hospitalization. Men are catheterized following this treatment, and there can be a degree of hematuria or blood in the urine that can persist for a few weeks, and a risk of blood transfusion following this surgery. Almost every man, from a sexual function perspective, almost every man will experience retrograde ejaculation, and there is a reported incidence of anywhere between 8 to 18% of erectile dysfunction. So at that end of the spectrum, a TURP, highly effective at unobstructing a blocked bladder, but there are some side effects to it. Really, a TURP has been the mainstay of how we've managed BPH for a long period of time. Many years ago, around 20 years ago now, investigation and research was pursued to try and perform cavitating surgery in a more minimally invasive way, and that really has led to the advent of laser. So there is green light laser prostatectomy. In its original form was PVP, and currently now green light laser is delivered with an XPS system, 180 watt XPS system, and a Moxie fiber, which in essence over the years has improved efficiency, durability, and our ability to remove more tissue. The advantage really to a laser prostatectomy over a standard TURP is that there is a shorter period of time in hospital. There's a lower risk of bleeding, a lower risk of blood transfusion, and from an ejaculatory perspective, many men still have ejaculatory dysfunction, but there is a significantly reduced risk of having erectile dysfunction, and the reported incidence is around 1%. More minimally invasive options have been on the scene over the last few years. Certainly in Australia and in my practice, UroLift was introduced back in 2013. We'll get to that shortly, but UroLift in essence is a series of medical staples that retract obstructing prostate tissue. It can be treated or delivered in the same day. There can be some irritability to bladder function for a few days, but the advantage is that there's no period of catheterization. Men are discharged on the same day, and there's minimal risk to sexual dysfunction, whether that be ejaculatory dysfunction or alternatively erectile dysfunction. Rezum, which you can see in the top right hand corner, Rezum is another new minimally invasive treatment. In my practice, has been around and being utilized for around 3 years. It involves the injection of steam into the prostate. It does, however, require a period of catheterization. There's minimal impact on erectile function, and there is a low, around a 5% risk of ejaculatory dysfunction. The bottom right hand of this slide, you can see that there are medical therapy for the management of BPH, which includes three main classes of drugs. There's the alpha blocker, 5-alpha reductase inhibitors, and PD5 inhibitors in the form of a low dose of Cialis daily. So let's explore all of those one by one, and we'll look at the benefits and the trade-offs for these. So with medication, as I alluded to on the previous page, there are several different classes of drugs that can be used, and there are benefits and drawbacks to using these particular drugs. So the standard entry medication for men who've got bothersome urinary symptoms really is to have an alpha blocker, and there are different types of alpha blocker on the market. Some are more selective for the prostate and the bladder neck, and others have a lower degree of selectivity for that particular area. The advantage to it really is that taking medication is reversible. It's a good entry level to determine if there is an improvement in urinary function with something which is relatively quite simple. The trade-off to medication really lies that men have to take ongoing medication to get the benefit and also the potential side effects from the treatment itself. So if we look at alpha blocker, three common brands, Flomaxtra or tamsulosin, there's UroRec, or there's Minipress, again, the UroRec and Flomaxtra, they are alpha-1A selective antagonists. They need to be taken every day. They are non-titratable, and the main side effects that we see basically are rhinitis or a stuffy nose and postural hypotension or dizziness and lightheadedness if men get up too quickly. At the bottom right hand of this screen, you can see there's Minipress there, which is prazosin. It is less selective, it's titratable. We usually start at a dose of 1 milligram at night. If that provides benefit, we can increase it to 1 milligram twice a day or 1 milligram BD to see if that improves effectiveness without causing troublesome dizziness or lightheadedness. When men take any of these medications, really, if there is any unwanted side effect that's experienced, the advice really is to discontinue its use. UroRec, which is newer to the market, Solodicin, another alpha-1A selective antagonist, 1 tablet per day, can be as equally efficacious as tamsulosin or Flomaxtra with a similar side effect profile. Duodart is combination therapy. So Duodart contains a 5-alpha reductase inhibitor as well as an alpha blocker, and the 5-alpha reductase inhibitors are appropriate medications for a subgroup of individuals. So with the introduction of a 5-ARI, there is cytoreduction of the prostate that occurs, which in essence means that the size of the prostate decreases in its volume by around 20 to 30% if you take the drug for around 6 months. So we get the immediate effect of alpha blocker, which is contained within Duodart, so that's tamsulosin. So there's the alpha blockade component, which can cause smooth muscle relaxation and an immediate improvement in flow, and then there is the benefit that comes from slowly reducing the size of the prostate if the drug is taken for long enough. Obviously, when there are 2 drugs in 1 tablet, there is a greater potential for side effect, and with the introduction of dutasteride, which is the 5-alpha reductase inhibitor component, it does run the risk of a reduction in libido and also the potential for erectile dysfunction. So in my practice, combination therapy with the use of Duodart is for men who prioritize less sexual function and from a prostate characteristic perspective have larger prostate, slightly higher PSAs, higher post-void residuals. This group of individuals are likely to get the benefit of longer-term combination therapy. Finasteride is a 5-alpha reductase inhibitor and can be used on its own for those people who wish to pursue medical therapy but either don't tolerate or don't want to be on an alpha blocker. So that's the current state of play when it comes to medical therapy. If we have a look now at some of the treatments, so this slide really highlights UroLift, and the easiest way to think of UroLift is that it's a medical or a surgical staple. It's a procedure that's done cystoscopically, which means it's performed via a telescopic camera that's inserted through the penis to allow retraction of obstructing prostate tissue, and then that tissue is stapled in place. On average, we use around 4 to 6 implants. For most people, the treatment can be done as a day surgery, and people are discharged usually without the use of a catheter. So if you have a little look here, this image highlights what a UroLift is, and as you can see, as described, it's a small staple in essence. There is a nitinol or a malleable metallic component, which is the top part here, and that is delivered through the prostate and anchored on the capsule of the prostate. And then we have a nylon thread and then a stainless steel anchor that is placed in the urethra. This is the delivery device through which inserted a telescopic camera to allow visualization. And so the following video really highlights a real-time case of a UroLift implant. So we're looking now inside the prostate. This gentleman has what we call bilobar obstruction. So his obstruction to the urethra is coming from both sides. This highlights inserting one of those clips that I highlighted on the previous slide. The nylon thread is tensioned, and we can see a band of tension here coming into view, and then the stainless steel urethral clip is deployed and the thread is cut. So on average we put 4 clips in here at the region of the bladder neck to create an open funnel shape at the start of the prostate to reduce the impact that obstructing tissue has. We've put in 2 anterior clips, and now there's the insertion of 2 additional clips slightly lower down in the prostate to create an open funnel shape at that point. Here's the final clip going into place. The nylon thread is tensioned again, the stainless steel clip is deployed, and there you can see an open funnel shape prostatic urethra to relieve the obstruction. So this treatment, in my opinion, having put UroLift in now for 7 years, there is approaching 8 years now, that there is a certain prostatic characteristic that is best suited for UroLift. In my experience, the more simple the obstruction, i.e. if it is bilobar, if the obstruction is coming just from both sides, if the bladder neck is open, if there's no median lobe, if the individual concerned doesn't have a significant degree of obstruction, in my opinion, these people get a longer term benefit from UroLift. If the prostate size starts creeping up, and by that I mean sort of plus 50 cc's, if they have more complex prostate anatomy, whilst they can get an immediate improvement with a UroLift, the durability begins to trail off and the likelihood of needing retreatment increases. This paper, which was published in the Journal of Urology, the Journal of Endourology a couple of years ago, highlights some of the data from a real-world population. That is to say, those people that are not part of a formal study. So they are all comers that present to various urologists for assessment of their urinary symptoms. It's multi-center, as you can see, it's international. There are authors on this paper that include people from Australia and also from the US. And it's a combination of our data and looking at the durability of our data out to 2 years. And what you can see in the top part of the slide, this is looking at international prostate symptom scores. So this is it's a questionnaire-based assessment to determine the severity of urinary symptom that someone has. And what you can see is following the insertion of a UroLift, individual symptom scores decline from an average of around 22 down to about 10, and although there is a slight upward migration in that score over time, crudely speaking, there is about a 50% improvement in symptom score that's durable out to 24 months. If we look at the following slide, it really provides us a review. In the top hand corner, it provides us a review of improvements in symptom score, and we break the size of the prostate down to less than 30 cc's or greater than 30 cc's. And what we can see is globally a similar trend out to 24 months. When we look at this bottom image here, it gives us a breakdown of the size of prostates that was most commonly treated amongst this entire cohort, and you can see that the majority of people did have prostate volumes that are certainly less than 60 cc's, but the peak treatment size is between 25 to around 45 cc's, and that really echoes my sentiment that the ideal individual for this treatment is someone that has more straightforward obstruction with minimal complicating factors. Okay, if we have a look now at the next treatment, and the next treatment here is Rezum. Rezum, another minimally invasive treatment. The way that Rezum works is by injecting steam into the prostate. And so on the right hand side of the slide we can see the endoscopic image. So this is what we see when we actually deliver the treatment, looking inside the prostate, trying to find the maximal point of obstruction just below the bladder neck. We then insert a needle into the prostate, and as you can see on the cartoon schema on the left hand side, steam is injected, and it's usually around 1 cubic centimeter of steam is injected to treat a particular area of BPH, or the benign prostatic enlargement. This process can then be repeated several times to allow all of the BPH tissue within the transition zone, or the central part of the prostate, to be adequately treated. You can see here again that another treatment is being performed. The needle is deployed on the right hand side, and you can see that the steam therapy is being used to treat additional adenoma. The following slide really is there just to highlight macroscopically what can be seen in response to the treatment. So the active video that we're seeing at the moment is a cystoscopic view of an individual who has significant BPH and what we call a large median lobe, which is a projection of the prostate up into the bladder. This acts as a ball valve obstruction that causes limitation or restriction to the flow of urine. That individual with a prostate size just over 50 cc's was treated with Rezum, and at 6 months he's undergone a cystoscopy, and you can see complete resolution of that median lobe and retraction of some of the obstructing tissue laterally. How does Rezum work? Well, in essence, Rezum, it's a form of convective wave technology. In essence, what this means is that water is heated, and water is heated from room temperature to around 100 degrees Celsius, and through that process there is the accumulation of thermal energy within the water vapor. That water vapor is then injected into prostate tissue, which has a crude temperature of around 37 degrees Celsius, and this injection of steam suddenly increases the temperature of the native prostate tissue, and over the course of 9 seconds, in essence, results in instantaneous cell death. The following slide here highlights the subtle differences between convective and conductive thermal energy. Convective energy, in essence, allows dissipation of the energy in the interstitium, which means that energy diffuses through amongst the cells, whereas with conductive therapy, there is transfer of heat from cell to cell. And so the cells that are closer to the energy source get hotter, and those that are further away are not heated or exposed to the same temperature changes. In essence, this slide really highlights a similar thing in that the injection of water vapor disperses amongst a predefined cavity, such as the transition zone or the central area around the urethra. That condensed energy is released, and it causes, in essence, denaturing of proteins, which causes tissue coagulation, necrosis, and denervation of adrenergic nerves. It's that denervation of the adrenergic nerves which results in subtle improvements in voiding function beyond about 3 weeks from the time of treatment. So something to be aware of with Rezum is that there is no immediate treatment and no immediate improvement in the way that people pee, and that there is a gradual, steady improvement from about 3 weeks. I highlight to people who undergo this treatment that there's no perception of benefit for about 3 weeks, but beyond 3 weeks, out to about 3 months, there is a gradual, steady improvement in the way that people void. This slide here is highlighting some of the zonal anatomy of the prostate, which may be of more relevance to medical practitioners that might be watching this video. In essence, there are 3 key zones that we need to be aware of. The transition zone is the central part of the prostate, which is prone to BPH, as is the central zone, which can be a projection forming a median lobe into the bladder. The peripheral zone, or the outer aspect of the prostate, is that part which is more prone to the development of prostate cancer. This slide really just highlights from an interest point of view what happens sonographically when Rezum is used to treat BPH. On the right hand side you can see the endoscopic view, and on the left hand side is a transrectal ultrasound to record what happens internally when Rezum is deployed. You can see that the needle is inserted into the BPH tissue, and then the treatment course, which takes 9 seconds, is then delivered. You can see a gradual opacity developing within the treatment zone, and that is consistent with delivery of that thermal energy. Out of interest, this slide really is an MRI that is done a week following the procedure, and you can see highlighted here this is an MRI scan showing the transition zones that have been treated, and around 3 months following the procedure, a reduction in the size of the prostate and resolution of the size of those transition zones. So what can men expect? Well, in essence, men can expect a significant improvement in their questionnaire, which is that IPSS questionnaire. And so from a scientific point of view, the IPSS is how we objectify improvements in people's voiding function. If we look across the board, people that have had Rezum, the average improvement is an improvement of 12 points. But of those individuals whose baseline score starts above 19, we can expect a slightly bigger improvement of about 14 points. Now, by way of comparison, what is expected if people have a TURP on average is 15, a laser is 14, and if people have alpha blockers, we can expect on average a 5-point improvement. This graphical form really highlights what we can expect out to about 3 years following a Rezum treatment. And in essence, what it shows is that we can expect to see about a 10-point sustained improvement out to 3 years. Qmax refers to the pressure that people generate when they pee, or the pressure of their flow. And at baseline, we can see on average people have a flow of 10. It does peak at over 16, so that's an improvement of almost 6.5 mils per second at about 3 months. And if we get out to 3 years, there is a slight decline, but overall that improvement is at about 3.5 mils per second. There was a study published in the Journal of Urology back in 2018 that looked at a comparative perspective of those people that were treated in essence with a duodide type product. So they had a combination of alpha blocker and also 5-alpha reductase inhibitor. And they compared those people. That data came from a pivotal trial which was called the MTOPS study. That in essence was the medical therapy of prostate symptoms, and it was published now around 20 years ago. And it looked at treating men with significant BPH, lower urinary tract symptoms related to BPH, and it looked at treating those men either with an alpha blocker, a 5-alpha reductase inhibitor, or a combination of those two. And so in this publication a few years ago now, what the authors did was to compare the outcomes of individuals who were on combination therapy in the MTOPS trial with those people who had undergone a Rezum treatment. And if we look over here on the right side, this is the purple line is combination therapy, the blue is Rezum, and we're looking here at the IPSS, which is that symptom score. And you can see a very similar trend that is durable and equal in essence out to about 36 months. When we look at the Qmax, or the improvement in flow rate, we can again see we get a more marked improvement in Rezum at the 3 months when compared to combination therapy, but out to about 36 months, similar improvements in flow rates. So in essence, the conclusion of this study was that having a Rezum or having combination therapy was equally efficacious, and ultimately then it comes down to individual choice as to whether or not they would rather have a tablet to manage their urinary dysfunction, or if they would rather have a one-off treatment without the ongoing potential side effects from continued medical therapy. Okay, we're going to change gear now and have a look at green light laser, and this video really highlights how we deliver green light laser. So all lasers have a slightly different property, or they can be used for different aspects, and that really depends upon the wavelength of the laser. Green light has a wavelength of 532 nanometers, which in essence means that it is poorly absorbed by water and maximally absorbed by red things, and therefore we can use this tool in an efficient way to get heat into prostate tissue and remove obstructing tissue. There was a publication in the Journal of Urology several years ago. It was a randomized controlled trial, international multi-center, comparing in essence green light laser prostatectomy versus the standard of care, which was TURP. The trial was called the Goliath study, and it presented 2-year data in essence. Just under 300 people were enrolled in the study, and around 140 individuals were treated in both arms. If we look at the prostate size of the two cohorts at baseline, they're very similar at just under 50 cc's, and at 2 years following treatment, we had a similar reduction in the size of the prostate that was not statistically different. The same can be seen for post-forward residuals, around 110 mils at the start, and they had declined to 45 and 35 mils respectively at 2 years. Again, with PSAs, we're seeing a decline of around 50% in PSAs from pre-treatment to 2-year values. And when we look at the improvement in symptom scores, if we start with quality of life, the quality of life around 4.5 down to 1.3 and 1.2 for green light and TURP respectively. If we look at side effect profile that was reported in this particular paper, reoperation in the first 6 months was slightly more common in the TURP group, and between 7 and 24 months was slightly more common in the green light laser prostatectomy group. The summary from this publication was out to 2 years, green light did provide a durable surgical option for the treatment of BPH, and the efficacy and side effect profile is not dissimilar between the two treatment choices. Locally here in Australia, several years ago, we had a multi-centre collaboration from groups from South Australia to Tasmania, New South Wales, and also here in Queensland, looking at our outcomes using at that time, the new 180 watt XPS green light console. The patient data here really highlights that at baseline we had symptom scores that were in the severe category of 25, that at 3 months had reduced to 7, quality of life improvements from 5 to 2, flow rates which improved from 7.7 to 18.4, and residual volumes which declined from almost 150 down to 38 mils. So what of those individuals that have massive BPH? So these are people that have prostate volumes, in my definition, prostate volumes over about 120 cc's and can extend very rarely, but up to around 300 cc's and sometimes even greater. As you may have gathered thus far, different treatment choices are suitable for different men, and it's not a one-size-fits-all. Certainly size, shape, presence or absence of a median lobe, whether or not people are obstructed, as well as patient characteristics, their age, their health, and their overall well-being. All of those aspects come into play when deciding on which treatment choice is more appropriate for a particular individual. What this video highlights here really is a robotic simple prostatectomy. So this is a type of keyhole surgery, and it is a form of management for people that have very big prostates. In essence, what you've seen thus far is keyhole access into someone's tummy. We open up the bladder on the posterior aspect, and so this surgery is performed transperitoneal, so through the peritoneal or the abdominal cavity. It is performed in a transvesical fashion, which means that we do the operation through the bladder itself. And the steps that you're watching now, in essence, are the enucleation of the transition zone. You may remember that we looked at the zonal anatomy of the prostate earlier, and in that zonal anatomy, the transition zone, or the periurethral zone, is that part of the prostate which is prone to BPH. That's the part that enlarges. And so what you're seeing here is a video that is sped up a couple of times in the interests of time. And what we're seeing here is the transition zone that is being peeled away from a compressed peripheral zone. And so we are slowly teasing away the entire overgrown component of the prostate to leave this gentleman just with a capsule, in essence, to leave him just with the shell of the prostate to unobstruct his bladder and allow resolution of his urinary symptoms. So this treatment choice is a very good option for those people that have very enlarged prostates, that have a durable life expectancy and want a sustained improvement in the way that they pee. It can also offer an advantage in terms of being able to treat simultaneously bladder stones that may or may not be present at the time of surgery. Coming around the front now, peeling away the last part of the BPH adenoma, so peeling away the last part of the transition zone. You can see that this operation is done under direct vision, which is different from the historical counterpart. This surgery, which historically used to be done as an open operation, was called a Millen's prostatectomy, and that type of surgery was done almost exclusively by feel, in that visualization within the prostate was nigh on impossible when this surgery is done in an open fashion. And so the advent of robotic surgery really has allowed us to perform surgery that otherwise required a longer hospitalization and a greater risk of bleeding or blood transfusion. So the transition zone has been removed, a hemostatic agent is applied, a pause is then undertaken before performing the anastomosis to bring down the previously divided edge of the urothelium inside the bladder and to secure this onto the divided urethra. So we re-epithelialize the urinary tract with a primary anastomosis, and in my opinion this facilitates a smoother recovery rather than having a raw surface inside the prostatic cavity that can take a longer period of time to heal. The anastomosis is continued around with the posterior layer being performed first, cinching down the previously divided urothelium of the bladder. The ureteric orifices are visualized throughout this process. The anastomosis now heads to the anterior aspect, and this is brought down to close off the defect. There you could just see urine emanating from the right ureteric orifice. We take a second stitch to close off the remainder of the defect, and this continues round on the anterior aspect of the divided urothelium through to the anterior aspect of the divided urethra. What you can see popping through the opening of the urethra is the end of an indwelling catheter that is used really to facilitate localization of that urethra, so we know where we are placing our sutures. You can see now the defect is almost completely closed off. A fresh catheter is inserted at the end of this procedure, and then the vesicotomy, which is the transverse incision that we made in the bladder and the posterior wall of the bladder initially to gain access down to the prostate, is then closed off. Men usually discharged on day 1 following this surgery. They are discharged with their catheter in place, and they keep their catheter, usually because of convenience. They keep it for a week, return to the ward, and undergo a trial void. That is performed with sending off a urine specimen beforehand to ensure there's no infection. An antibiotic tablet is given, and men spend usually a few hours on the ward, ensuring that they're emptying their bladder well before they're discharged. Routinely, we follow men up at the 12-week mark following this surgery. At that point, we perform an IPSS questionnaire to assess that exactly where their bladder function is at. We also do a flow test in the office to ensure that they are suitably unobstructed, answer any questions that a man may have at that stage. In terms of ongoing follow-up, I recommend to these men that they have a PSA, usually 6 months following their surgery, to obtain a new baseline in their PSA, and then continue on with annual PSA testing, either at the prostate clinic or alternatively locally with their GP. We are now just closing off that previously performed vesicotomy to ensure good closure of the bladder, and that's the termination of the procedure. Okay, so to summarize, you can see that in 2021 there are multiple treatment choices for the management of BPH. BPH really can be divided into those individuals that have symptoms and those individuals that can have symptoms plus or minus complications to their obstruction. Complications from the BPH include recurrent UTIs, stones within the bladder, bleeding from their prostate, or not being able to pee at all. And at the end of the line, that can include pressure being transmitted up to the kidneys, which can impair filtration and result ultimately in impairment in renal function. For those individuals that do not have complications from their BPH, which treatment will depend ultimately on how much bother they have from the way that they pee and whether or not they are looking for ultimate durability in their treatment, or whether they would rather have something that may compromise on a durable perspective but will offer advantages either from an ejaculatory perspective or from a perioperative point of view. So the management of BPH now has moved significantly from either alpha blocker or a TURP, and there are several solutions available to men. I think it's important that men be evaluated completely so that they can determine which solution is going to be more ideal for them. Hope this helps. If there's any questions, please leave them below. Subscribe to our YouTube channel, where there will be more content along this line to hopefully provide some information for people about various issues from a men's health perspective. Thanks again.